Hello, friends. My name is James Ross, and I'm a palliative care physician. I'm going to be sharing some pearls with you on how to have a goals of care code status discussion with high risk patients during a public health emergency, such as we have now seen with COVID 19. This presentation was designed to help my colleagues who are at the very front of the front lines: ER providers, residents, hospitalists, and critical care providers. Thank you for your dedication, selflessness, and hard work. You are making a difference. So the purpose of this presentation is to share with you how to conduct a goals of care code status conversation with patients who are at high risk for a poor outcome when infected with the COVID-19 virus. I want to provide a roadmap or template that you can follow with the help of an acronym that I came up with to help you as you conduct these discussions. It's a template that can be used for really any goals of care code status discussion. I will also demonstrate for you how I might have a goals of care discussion with a patient or a patient's family member. Now, it's never easy to deliver bad news to patients. It's not something that is comfortable for us or comes naturally. It's also very difficult to share potential bad outcomes. It's not something that most of us do frequently. As we have seen, the COVID-19 pandemic has really changed the way we are doing things in healthcare. We're having to think differently and act differently. It's pushing us way out of our comfort zones. And in times of pandemics, we move away from a patient-centered approach to a more population-centered approach. Several institutions are developing medical decision-making algorithms and protocols for the allocation of scarce resources. And bioethics principles are being applied to undergird these processes and protocols. Let's now go to where these processes are going to first be implemented, the emergency department. Our scenario is going to address the high-risk COVID pending patient. COVID fatality data from around the world identifies who is most at risk of dying from COVID-19. Patients who need this clear goals of care discussion are those patients who are 60 years of age and older, COVID-19 pending, or maybe they're known positive, and who are full code or have an unknown code status. Like anything in healthcare, the patient experience and even outcomes are often determined by communication. Communicating very difficult news is obviously challenging, even under normal circumstances. However, in the face of this COVID-19 pandemic, we see that communication can be way more challenging. Healthcare providers are in full PPE attire, wearing N95 masks, and it makes speaking and communicating very difficult. And additionally, hearing may be further hindered in the elderly with the noise of all the air filtration systems. So we must speak loudly and clearly and do our very best in these less than ideal circumstances. To help guide you through the code status discussion, I have developed the acronym COVID, which stands for completed, ownership, validate, inform, and discuss. Let me explain what each word means in the context of this discussion. Completed has to do with whether or not a patient has completed an advance directive. This is imperative at the outset, and it gives insight into what the patient's wishes really are. Other C words that you could consider at this time are compassion and commitment. The second word, ownership, speaks to the responsibility that healthcare providers have to our patients and to society as well. It also speaks to our responsibility to assess the patient's values and goals. Ownership also reflects the importance of shared decision-making and cultivating a sense of partnership in this process. Validate. This is demonstrated when we acknowledge the patient's fears and concerns while showing empathy. We legitimize their feelings and communicate dignity and respect for our patients' lives. Inform. This is obviously where we share and educate patients on the data we have on the disease they're suffering from. We also share specific information about prognosis to help them arrive at an informed decision. It is also a really good reminder to share information about CPR, explaining how and when and why it is performed. And at times, patients may need to be informed that CPR may not be offered at all. And finally, discussion. This allows the patient's wishes and preferences to be expanded on and allows for patients to voice their concerns and even their objections. This is also a reminder to discuss DNR by exception when special circumstances apply. Now, these words and concepts do not have to be followed in any particular order. It's just simply a tool to aid you in these discussions. So I'm going to share with you an example of a goals of care discussion that I might have with the patient. It can also be applied to discussions with family members when the patient is incapacitated. So it might look something like this. Hello there, I'm Dr. Ross and I'm one of the doctors involved in your care. This is understandably a very scary time for you, but I want you to know that we're going to give you the very best care that we have to offer. Now at this time, I'd like to ask you some questions and talk about coronavirus and how it affects patients like you. And together, we're going to need to navigate some really important decisions about your medical care. So let me ask, have you completed an advance directive or other documents? Have you named a healthcare proxy? And if so, what do these documents say? And who have you named, and are they aware of your wishes? If you have not, have you had conversations about what matters to you should you become ill enough not to be able to speak for yourself? Okay, let me share some information about coronavirus. As you likely know, COVID-19 is a life-threatening illness, particularly in patients like you. If you should test positive for COVID-19, there's a very significant risk that you may die from its complications. Because we do not yet have a cure for COVID-19, our medical care is primarily supportive and will treat your symptoms very aggressively at all stages of this illness. However, if the illness gets worse, CPR and the use of a breathing machine will likely be unsuccessful. Statistics are showing us that should you need a ventilator or an ICU level of care, over 80% of patients like this simply don't survive. Now, based on everything we are seeing, these measures like ICU level of care and CPR are not something that we recommend. Let me emphasize that you'll receive the best treatment that we can give, but should there come a time that your death might be imminent, we forego these non-beneficial measures and make sure that you're very comfortable and that you do not suffer. I know this is a lot to think about, but I'd like to discuss your thoughts and preferences about this. Now, at this time, the patient can share his or her feelings, concerns, and maybe even ask some questions. If the patient then decides to proceed with DNR, DNI, do your best to reassure the patient that they're still going to receive great care per all the medical decision-making protocols that have been developed. Verbal consent by itself may be adequate in this scenario. Make sure that it's an acceptable alternative in your institution to minimize contagion from obtaining written consent. Documentation of the conversation and verbal consent is really important. Now let's just say that the patient, though, wishes to remain full code. It might be appropriate at this time to bring up DNR by exception. This is how I would share the information with the patient. Okay, I would like to make you aware of some really difficult decisions that are being made in hospitals all across the country during this crisis of COVID-19. Now, should there come a time if you're just so sick that your death is imminent, the doctor may have to make some really tough decisions to make you DNR if he feels that CPR or life support will not reverse the disease. That means that if you should die and he feels it's not going to help you, they're not going to do chest compressions and they won't put you on life support. Now, in these circumstances, we would shift your medical care toward focusing on managing your symptoms to ensure that you do not suffer at the end. I know this is difficult, but I want to make sure that you understand what I'm saying. Do you have any questions for me? Now, this may sound really harsh, but standards of care are going to shift in a pandemic when resources are scarce to focus on population health. With patients whose death is imminent and the physician believes that CPR and intubation won't provide benefit to the patient, that provider can go ahead and make the patient DNR by exception. And this is based on ethical and legal grounds. There are some institutions around the country that have actually considered a universal DNR by exception order for all the patients who test positive for COVID-19. This, though, is really not a universally accepted model, as various centers and regions have thus far been affected differently by this pandemic. So, as we wrap up, remember COVID. Completed, ownership, validate, inform, discuss, and DNR by exception when discussing code status. I really hope that this has been helpful to you and provides a template for you to follow. Again, please feel free to use the acronym and make this discussion your own. The important thing is that you have these discussions and cover these topics. These are really challenging times, and it requires all of us to have these really difficult conversations. And these conversations are necessary to serve our patients, but also to help preserve life and the well-being of others, especially when resources are so scarce. Thank you so much for your time, and know that you are making a difference.